Hello everybody and welcome to join me again. On this lecture I will describe cultural translation in implementation research using the Kerala Diabetes Prevention Program in India as a case example. I've been involved with this project from the very beginning, together with Professor Thankapan and his colleagues from the Sri Chitra Institute in Trivandrum, Kerala, and Professor Brian Oldenburg and his team at the University of Melbourne in Australia. On this slide you can see some of the people who made this project happen, so let me introduce them to you. So there's of course Brian, who was the principal investigator in Australia, and Professor Thankapan, the principal investigator in India. Meena Devadanam was involved in the early stages of this project and led the needs assessment study. Sajita Balachandran was the project manager in India, and she did a huge job leading the team that conducted all the field work for the evaluation trial. Elizabeth Matthews did a remarkable job as an intervention manager, both in the design and the implementation phases of the study. Satish, whose last name I'm not even going to try to pronounce, and Sarah Aziz, who are both also involved in the organization of this school, did their PhDs on the project. Satish evaluated the recruitment as well as the effectiveness outcomes, while Sarah evaluated implementation outcomes, and she will be talking about her study later during this school. With Professor Thankapan, Sajita and Elizabeth, there was this whole team that did an amazing work pulling through this complex intervention and all the field work related to participant recruitment, risk screening, clinical and other measurements in mobile clinics, implementation of the intervention, and stakeholder collaboration. I will describe the process from needs assessment to cultural translation of the program and testing it in a hybrid 1 effectiveness trial, and more recently efforts to scale up. This is an old slide that throws us back to year 2001 and shows our background for the study. At the time we knew that type 2 diabetes could be prevented with lifestyle changes. Some major efficacy trials had established this. Also, we knew that the burden of this disease was rapidly increasing in low and middle income countries, but there the resources for prevention and management were scarce and infrastructures were lacking. This slide shows the magnitude of the problem, especially in sub-Saharan Africa, where the increase in percentages is estimated to be the highest in the whole world, and Southeast Asia and India, where the case load is projected to increase more than anywhere else in the world. In my theory lecture earlier during this school, I told you about the Go Lifestyle implementation trial in Finland. I'll tell a little more about the study because it formed the basis also for the KDPP. The Go Lifestyle implementation trial built on the findings from the Finnish diabetes prevention study that had shown the effect of specific lifestyle changes in preventing type 2 diabetes. We wanted to study participants' lifestyle change process with determinants and behavior change techniques based on behavioral sciences. Also, we wanted to design an intervention that would be feasible for the implementation in routine healthcare settings with much more limited resources for lifestyle counseling than in the DPS RCT, which had highly experienced dietitians giving the counseling. So we tested a nurse-delivered group counseling model. Our approach was less intensive. Participants had only 6 small group meetings in comparison to the average 17 individual sessions of the original efficacy trial. Still, using the DPS lifestyle change objectives as a benchmark, our findings were reasonably good. The achieved weight loss, here shown as the body mass index, was sustained also in the 3-year follow-up, and findings on glucose tolerance were encouraging. Process evaluation of the Goal Lifestyle implementation trial also supported the theoretical model underlying the intervention. By 2009, we had published the outcome evaluations of the Goal Lifestyle Implementation Trial, and the intervention had also been culturally translated to and replicated in Australia. Around that time, Brian Oldenburg and his colleagues with whom he had ongoing collaborations in Kerala decided that it would be a good idea to adapt and test the model in India. We started with a comprehensive needs assessment that included a systematic review of key research literature, a review of relevant policy documents, and focus groups conducted among individuals with a high risk of progressing to diabetes. We organized our findings using the Precede-Proceed model. You can see that diabetes was really a severe health problem, and also that prevalences of risk factors were really high both among men and especially among women. Both the individual's behavior and lifestyle, as well as the environment, were driving these trends, with several important determinants identified on both levels. Individual perceptions were not in favor of lifestyle change, and social and physical environments were also largely unsupportive of healthy lifestyle. We also saw that interventions relied mainly on provision of information, and there was a short history of policies and programs related to NCD prevention. Looking more closely at perceptions related to diet, they revealed a culture that was actually counterproductive for healthy eating. After we had published the outcomes of the GOAL study in Finland, a health psychologist colleague of mine had asked me what my next study with the HAPA model would be. At the time, I thought it was a crazy question, as I did not see the point in committing to using any one single theory. Also, HAPA was developed with Western individualistic populations, and I thought it would hardly be useful in a country like India. However, to my surprise, the needs assessment pointed at constructs from the model as important personal level determinants. It became clear to us that these were some of the factors that we needed to address in our intervention. Based on the needs assessment, we started to plan for cultural translation of the intervention. This open access publication was led by Elizabeth Matthews, whom I already introduced to you. The article gives a detailed description of the process. Following the intervention mapping approach, we defined program objectives, identified theory-based determinants, defined theory-based methods and behavior change techniques, as well as practical intervention strategies. You can find this table in the same publication. We designed a peer support program that included small group sessions, similarly to the GOAL program in Finland. However, in Finland we have a universal health coverage, and our public primary care is also doing preventive work, especially by primary care nurses, and they had delivered the program. In India, the situation is quite different, and there wasn't a group of professionals who could easily take on this task. So we decided that it would be the most feasible solution to recruit and train peer leaders. The peer leaders were selected from the small groups by the group members and trained and supported by the project. So the training and ongoing support program was another level intervention. There were, however, accredited health workers, or ASHAs, working in the communities, and they were recruited as local resource persons to support the peer leaders and the group members, and they also received training by the program. The small group sessions were designed to follow this self-regulation model with assessment by self-monitoring, goal setting and planning, and support from peers, family, and wider community. In the program, we really saw the individual as embedded in the social networks. Furthermore, community engagement became an important component of the program. Before going to full trial, the program was piloted, and we identified some challenges such as low participation among males, as well as perceived low relevance of prevention, as participants felt that their energy went into management of the disease among their elderly family members, and they were reluctant to put the focus on prevention. So we recruited males as peer leaders and found also other means to boost male participation. We also added another education session to explain how the same lifestyle change strategies were equally important for management and prevention, and how preventing the disease would help to ease the burden on their children, as they would not have to care for ailing parents in the future. Implementation of the intervention components followed these 4 phases, which also had slightly different focal areas. You can see that in addition to the levels of participants and family members, as well as peer leaders, we also had activities on community level. In the beginning, this was mostly a question on how the community could support the program objectives. However, during the last 6 months of the intervention, participants were eager to find ways to support their communities in healthier lifestyle, and they came up with ideas for community activities, which the KDPP project then opportunistically supported. Here is the study design for testing the effectiveness outcomes that was published in the protocol paper. There are also several publications on the evaluation of the KDPP. Sarah will talk about those in detail in her lecture on the implementation evaluation of the program. After the KDPP trial, the team in India started forming partnerships for scaling up the program. The first scale-up project was conducted as a non-research collaboration with the Kudumbashree State Mission. Kudumbashree is the poverty eradication and women empowerment program implemented by the State Poverty Eradication Mission of the Government of Kerala. The name in Malayalam language means prosperity of the family. Kudumbashree has a total membership of over 4 million women who each represent one family. This women community network covers the entire state, and in 2019 it reported having 300,000 neighborhood groups affiliated to almost 20,000 area development societies and over 1,000 community development societies operating at the local government level. So this is a 3-tier network system. So this organization has the capacity to reach a really significant proportion of the population in Kerala. And it already had infrastructure that could be utilized for implementing the program and training peer leaders. There was also a good fit with the goals of the organization, as diabetes puts a heavy burden on families in terms of health and well-being, as well as economically. The project provided intervention materials and training to 118 KSM trainers and carried out project evaluation. The KSM trainers trained over 15,000 peer leaders for the neighborhood groups, who facilitated groups for over 380,000 women as well as their family members. I already referred to the second scale-up project during my earlier talk on theories, models and frameworks. It is a GACD and NHMRC-funded research project with Brian Oldenburg from the University of Melbourne as the principal investigator in Australia and Sri Chitra Institute in Kerala and the National Institute of Epidemiology as the main research partners in India. There, Dr. Jimon and Dr. Ganesh are the principal investigators in these two institutes. The project is conducted in partnership with the health departments in Kerala and Tamil Nadu. And unfortunately, the project is now on hold because of the COVID-19 situation, but our plan is to follow the IHI framework for going to full scale as soon as the situation allows us to move forward. So first, we will map the existing program components for hypertension and type 2 diabetes control in the two states. Then we will analyze enabling factors and barriers for implementation at patient and provider levels. Then define program components, delivery, and targets for scale-up. And in this phase, we will focus on 3 dimensions of scale-up: the population coverage, the scope of the intervention package, and integration to health systems. Finally, we will test the scale-up with the hybrid 2 design trial, assessing both the effectiveness and the implementation outcomes. During these phases, we will identify and address adoption mechanisms and support systems. And finally, the phases will provide the necessary outputs for going to full scale. From the research aims, you can also identify some of the other theories and frameworks that we are using in this study and that I referred to in my earlier lecture. This photograph was taken during our project meeting in Chennai last February. We were lucky to have the meeting just in time before the pandemic hit the whole world and made it impossible to travel and meet with colleagues. I want to acknowledge especially Dr. Bipin and Dr. Gerard, who are the NCD nodal officers in the Kerala and Tamil Nadu state health departments. Also, Dr. Jimon, who is the principal investigator at the Sri Chitra Institute in Kerala, and Dr. Ganesh, who is the principal investigator at the National Institute of Epidemiology in Chennai. And also our project manager in Australia, Dr. Tilahun, who is also a facilitator during this school. Looking out of the window here in Helsinki, Finland, it's rainy, it's dark, it's cold, it's windy. So I want to leave you with these sunny pictures from Kanyakumari in Tamil Nadu. Thank you for your attention, and I look forward to receiving your questions and comments at our plenary session.